So again, my name is Dr. Sharon Adler. I'm one of the clinical faculty at the California Prevention Training Center, and I'm welcoming you all to our STD Clinical Update webinar. Today, we are so lucky we have Dr. Kelly Johnson joining us to be talking about syphilis, giving us a case-based review and update. And before we actually launch into the webinar content, I'm going to do a little bit of review with some introductory slides talking about CME requirements and some Zoom housekeeping slides before I turn it over to Dr. Johnson. So let's see. Here we go. All right, so a bit more about the California Prevention Training Center. We are a multidisciplinary capacity building assistance training center. We are funded by the CDC. And we were a member of the National Network of STD Clinical Prevention Training Centers, otherwise known as the NNPTC. We provide virtual and in-person training events. We provide TA or technical assistance. We provide clinical consultation, clinical tools. And to learn anything more about us, you can visit our website, which is listed down below. And you can also visit the NNPTC website, which is listed at the bottom of this slide. I want to share this really wonderful resource with you. It is the STD Clinical Consultation Network. So this is a network that is funded by the CDC, and the California Prevention Training Center provides subject matter experts for this consultation service. So if you have a complex STI case that you want to get some input on, you can submit your request online at this website, stdccn.org. And we will respond either by phone or email per your request within 1 to 5 business days. In terms of disclosures, we do not have any disclosures, financial disclosures for today's webinar. Regarding CME, here is our CME disclosure, and today's webinar, if you're attending in full, you can receive 1.5 credits. And this slide has a bunch of details about CME requirements. I know there's a lot on this slide, but I'll go through this because we get questions about this all the time. So to earn your 1.5 CME units, that's what's available for this course. Nurses can receive continuing education credits if they accept the AMA credit category 1. In order to receive the CME credits, you need to attend the webinar live and full. So you already have to have been registered for this webinar. At this point, registration is closed. It closed yesterday at 3 p.m. Again, you need to attend the webinar live and full. So if you are listening via recording, unfortunately, we are unable to provide partial CME credit for folks who are viewing a portion of the webinar or for folks who are viewing the webinar recording. And so we actually take attendance once you sign into this course. So attendance is recorded as you sign on. In addition, to receive CME, you need to complete the post-course survey evaluation. And you will receive that. You'll receive a link to that post-course survey evaluation 24 hours after this webinar. And this link to the post-course survey evaluation is going to come from the training at nnptc.org email address. So make sure that you have that as one of your safe and trusted senders emails. And also check your spam and junk folders if you do not receive a post-course survey evaluation within 24 hours after this course. Regarding CME notification, if you have met the CME requirements, you will get an email from us, and our email is captc.ucsf.edu. You're going to get that notification by May 1st, and then this will give you a link to obtain your CME certificate. And to add another organization to the list of organizations I've already mentioned, our CME provider is the University of Nevada, Reno, and that's you'll be able to print out that certificate or keep a copy of that for yourself. And the email regarding this CME notification is going to come from us, captc.ucsf.edu. So make sure this is in your safe and trusted senders list. All right. Finally, a couple other things related to post-webinar materials. And so we get questions about this. So rest assured, you will be able to receive slide handouts and a link to the webinar recording. And this is going to be available 2 weeks after this webinar is completed. So you don't need to request these materials separately. You're going to get an email that gives you the slides and gives you the webinar recording. And that's going to come from us, captc.ucsf.edu. And so that this should be an email that's in your safe and trusted senders list. All right, a couple more details about how we're going to communicate during this webinar. So Q&A will be turned on, and so you can ask questions during the webinar using the Q&A function. And so at the bottom of your screen, you should see a Q&A icon. It looks like this right here. And so you could open that up. You can type in your question, and then you click send. And you can submit questions up to the last 2 minutes of the Q&A section of this webinar. And either myself or Dr. Johnson will be answering these questions, and we really encourage people to ask questions. It looks like we only have a small number of participants, so we want to try and make this as interactive as possible. Microphone, video, and chat are going to be turned off. If you have administrative questions, you can also submit them into our Q&A, and they will be answered by our clinical admin team, Elizabeth Olson and Lauren Blakely. And regarding the timing for the questions, you can submit them up to the last 2 minutes of our Q&A section. So throughout the webinar and up to the last 2 minutes. Any questions about CME or other things related to this webinar, our clinical program manager can assist you with these. Her name is Elizabeth Olson, and her email is down at the bottom of this slide, and you probably have already been communicating with her related to signing up for this class. All right, so we've got a small group, hoping more folks join us, but it really gives me great pleasure to introduce Dr. Kelly Johnson, one of my colleagues. She is the medical director of the California Prevention Training Center. She is also a public health medical officer at the STD Control Branch at the California Department of Public Health, and an assistant professor of medicine in the Division of Infectious Diseases at UCSF. She is board certified in both internal medicine and infectious diseases, and she works on the inpatient service at UCSF in ID. Her research interests include the intersection of HIV and bacterial STIs, as well as real-world implementation of HIV PrEP, and she's fabulous. And so I turn this over to her, and I'm going to stop my sharing so you can come on.
Thank you so much, Dr. Adler, for the introduction, and especially to all of you for being here today. Because this is a small group, I'm really hoping we can make this a little bit fun, a little bit interactive. I've put a lot of poll questions in the material, but I think with such a small group, feel free to put your questions in chat, in the Q&A, and we can try to address them sort of in real time, have a bit of a dialogue. The point of this is to have sort of a kickoff event for STI Awareness Month, which is April. So give me a second to start sharing my slides, and we'll be going over some syphilis cases. All right. Look okay, Dr. Adler?
Looks great.
Good. Okay. So hello, everyone. Again, that's me. I'm Kelly. Here are the things I'm hoping we'll be able to do by the end of today's session. I'm hoping to help you list common causes of genital ulcerative disease, which of course that list includes primary syphilis. We'll be interpreting results of traditional and reverse syphilis screening algorithms. This is a tricky topic. We'll be spending some time on that. I'll be going over the clinical significance of changes in non-treponemal titers, so your RPR, your VDRL. How do we interpret changes in the numbers that you see with those tests? And then if you take nothing else away from today, I am hoping that you'll be able to name a resource for help interpreting different combinations of serologic results for syphilis. So, first audience question, and I'll ask Dorothy if you can go ahead and launch the first poll. I'm going to ask all of you to just indicate, so I know who's here in the audience with us today, if you are a clinician, a DIS, if you're some other non-clinical staff, or something else. Give it just a second for folks to think about it. Okay, let's see the poll results. Wonderful. Okay, so we have almost 90% of folks who are clinicians in the audience, and then one person who is something else. I should have put more choices on here. If that one person wants to put what they are in the Q&A, I would welcome that information, but I am happy that there are a lot of clinicians here today. This is a rather clinical talk. I'm hoping to kind of use cases as a prompt for diving into some of the trickier issues around syphilis interpretation. Okay, we have a CMA here. Thank you for telling us who the mystery person is. Glad to have you with us as well. So I'll start with just a little bit of background. If you attended our larger half-day training a few months ago, you may have already seen some of this information, but I just want to level set a little bit and point out the importance of what we're talking about today. So this is the CDC's STI surveillance report. This is the most recent one. It is from 2022. And what I really want to highlight is what's in the red box here. If you look at 2018 and compare that to 2022, there was an 80% increase in cases of syphilis. And perhaps even more concerningly, there was an almost 200% increase in cases of congenital syphilis, which of course is mother or pregnant person to child transmission of syphilis. And that can result in significant morbidity and even mortality for the babies. If we dive in specifically to the congenital syphilis question, this was a vital signs report published by the CDC last fall that really delved into the issue of congenital syphilis. And this is one of the more impressive graphics, I think, from that publication. It shows you that back in 2012, there were around 300 some congenital syphilis cases. And then if you fast forward to 2022, there's been a 10-fold increase in those cases in babies, such that as of 2022, we had almost 4,000 cases of congenital syphilis. This is a quote that I like from the CDC. I think it's sobering. I think it drives home the point of why this matters. But up to 4% of infants who are born to persons with untreated syphilis may be stillborn or may die from the infection. And in today's day and age, this is really, really horrible because syphilis is a preventable and treatable infection. Looking a little bit more about the importance of diagnosing and treating people, particularly in pregnancy, with the goal of preventing congenital syphilis. This slide is a paper from a publication that I like. This is a figure showing the percent of preventable congenital syphilis deaths on the y-axis versus the gestational age when the pregnant people were treated for syphilis. And this is a modeling study. And what they found was essentially that the majority, almost 70% of stillbirths from congenital syphilis were probably avoidable if the pregnant folks got treated by 21 weeks gestation. So again, just driving home that point that congenital syphilis can be fatal, that it's preventable, and the only way we're going to diagnose and treat it is to find syphilis in pregnant people and in their non-pregnant people that they may be having sex with. So that's just a little setting the stage around why this topic matters. Syphilis is increasing. Congenital syphilis is one of the more impressive and horrible outcomes that can happen, and we can prevent it by really diving into syphilis. So, some basics. Syphilis, of course, is caused by a bacteria, Treponema pallidum. Its incubation period is on average about 3 to 4 weeks, but it can be quite long, actually. The incubation period can be up to 90 days or 3 months. And this is a super interesting infection because of its natural history. Syphilis actually causes a systemic infection that has these episodes or stages of active or symptomatic disease interspersed by periods of latent infection. And during those periods of latent infection, people will have no signs or symptoms of their infection, and they won't know to seek care, and you won't find it unless you know to screen for syphilis. How is it transmitted? Of course, the main route is via direct contact to infectious lesions or sores. But syphilis can also be bloodborne, so rarely there might be cases associated with transplantation of organs. And important for the purpose of our talk today, of course, syphilis can also be transmitted in utero from pregnant person to child via the placenta. Here you see that syphilis natural history. And again, if you attended our event a couple of months ago, you have seen this slide before, but I'm just gonna bring back a few of these points because it's so confusing to understand syphilis. So on this slide, you see that natural history. As I mentioned, This infection is characterized by episodes and stages of active disease, during which time, as I said, patients will have signs and symptoms, but those active periods are interrupted by periods of latent or totally asymptomatic infection. These arrows down at the bottom are meant to show you that serious complications, including neurosyphilis, ocular syphilis, or otic syphilis, as well as transmission in pregnancy, can actually occur at any stage of syphilis. Okay, I'm done with my background and our brief introduction to syphilis basics, and we are going to jump into a case about which I'll ask you some questions. So this is a pregnant female with a genital ulcer. So let's say you have a 25-year-old bisexual female. She is pregnant at 28 weeks, and she presents with a mildly painful sore on her vulva. It's been there for 2 or 3 days. She doesn't have any history of genital herpes, and she doesn't have any prior history of syphilis. You ask a sexual history, and she says she's had sex with 2 men and 1 woman in the last 90 days. On physical exam, she has this lesion here. A little bit painful, not too bad. There's just one of these lesions, has some sort of raised edges, erythematous lesion, not a lot of exudates here. So you do appropriately think about syphilis, and you get an RPR, and thankfully your clinic has point of care testing, but the RPR is non-reactive. So you do your swabs for herpes simplex virus, and you do your swab for mpox as well, but those are pending. So how would you manage this patient? And you can go ahead and launch the second poll on slide 14. Thank you. So for this pregnant female with multiple sex partners and a vulvar sore, how would you manage her? Would you wait for the pending PCRs? Maybe this is herpes, maybe this is mpox. Do you presumptively treat now for syphilis? Do you order a treponemal test like a TPPA? Or do you do some combination of these things? Give it just a few seconds. This is a more complicated question. Okay, let's see. What do we think? Wonderful. Okay, we have a little bit of a spread here, but really good answers. So we're leaning towards just presumptively treating for syphilis or presumptively treating for syphilis and getting a treponemal test, which is what the majority of our audience is favoring. That is wonderful. You all have the correct answer. The correct answer is indeed to do both of these things, presumptively treat for syphilis and order a treponemal test. And we're going to go through the rationale behind this. But essentially, this genital ulcer is pretty classic for primary syphilis, and you really don't want to miss that diagnosis, especially in pregnancy, for all the reasons that I mentioned. Since tests like VDRLs and RPRs may be non-reactive early in syphilis infection, you should just treat presumptively if it's a high-risk scenario and you have high clinical suspicion. And it looks like you all were leaning towards that option. You should also order a treponemal test, like a TPPA, because, and we'll go over this in a bit more detail, but the reason is that treponemal tests like the TPPA can turn reactive earlier than non-treponemal tests. Again, the non-trep test being the RPR and VDRL. So you all were totally on top of this. The answer is get a TPPA and presumptively treat this pregnant person with a lesion concerning for primary syphilis. So let's talk a little bit about primary syphilis. Going back to our natural history slide, we're going to start on the left-hand side. So after exposure, as we discussed, there's this incubation period of 3 to 4 weeks, after which time the person enters primary syphilis. During this stage, a syphilis ulcer or chancre appears at the site of inoculation. And this initial lesion is a papule, again, appearing at that site of exposure and then growing and ulcerating, ultimately producing the typical chancre of primary syphilis. Classically, these ulcers are single, painless, they're indurated, they don't have a ton of exudate, and they can have these sort of heaped up or rolled edges that are a little bit rubbery in nature if you feel them. Patients may also have some localized regional lymphadenopathy on exam. And what's really important to note is that because these ulcers are often painless or minimally painful, they can go totally unrecognized, particularly if they're in places like the vagina or cervix or the anus or rectum, where the patient might not notice them and you might not either if you're not doing an exam in those areas. It's also important to note that the chancre of primary syphilis does go away on its own, even if the person never gets treatment. So because images are fun, here are some additional images of typical chancres with primary syphilis. Again, classically, this is a single, painless, indurated, clean-based lesion. It can have these sort of, I think it's shown well in our case patient, these sort of raised rubbery borders. And again, these might be unrecognized if they're in particular areas that aren't easily seen. These are the classic sort of chancre appearance. But of course, syphilis has been called a great masquerader for a good reason. So patients might have these really atypical chancres. These chancres can be multiple, they can be somewhat painful in the patient's experience. And these atypical presentations might be more common in folks who are immunosuppressed, like those with HIV, but that's not a hard and fast rule. So basically, if you see something like this, do still be thinking about primary syphilis, even if it's not raising your alarm bells for a classic chancre appearance. Now, as I mentioned, and this is important to know, primary syphilitic chancres can appear at any sites of inoculation, and that can include extragenital sites. So here you see syphilitic chancres on the lips, on the tongue, and even here on a finger. Just to round out the differential diagnosis and show some more pictures of genital ulcerative disease, this is herpes. Herpes classically kind of looks like what you see on this person's cervix here, a crop of vesicular or pustular lesions on an erythematous base. So this would be a classic appearance for a crop of herpetic lesions. As these lesions burst open, the skin underneath can start to ulcerate or erode. I think you see that well on the slide here, these erosions on this person's vulva. And those erosions or ulcerations can even become more confluent, like what you see on the right-hand side here. So that's herpes in classic form. Another cause, potentially, of genital ulcerative disease, of course, is a relatively new viral infection that is now known to be sexually transmissible, which is Mpox, formerly known as monkeypox. This slide does show images of Mpox. The first two images are the more classic appearance for Mpox. It can have these sort of well-circumscribed or circular raised lesions that they say they're deep-seated. Like if you felt them, you could definitely press on them. They would feel firm. They would be palpable. And then one of the pathognomonic features is that they have this central dot, this little central spot in the middle of them called an umbilication. So that's sort of classic Mpox, this image on the left and this image in the middle. The one on the right is a bit more atypical, and I think this one in particular would be easy to get confused for primary syphilis. And frankly, if you saw something like that and you had the resources to test for Mpox, I'd be thinking about testing for primary syphilis, for Mpox, and for herpes. Okay, so let's get back to our case. In this case, the provider made a bit of an error. So they thought, okay, the stat RPR is non-reactive, so they think it's not syphilis. They're going to wait for the PCRs. They also don't draw any serologic testing. They think it must be Mpox or herpes. But at 34 weeks, our patient gives birth. The baby does not appear well. They have a diffuse rash, they have copious nasal drainage, they have hepatosplenomegaly, they have some difficulty breathing, and in fact, they have to go to the ICU for further care. So what do you think is the most likely diagnosis for this baby? Is this toxo? Is this rubella? Is this CMV, congenital syphilis? And you can go ahead and launch the next poll, please. Thank you. I'll ask you all in the audience to cast your votes. What do you think? Is this a trick question? Okay, you can go ahead and show the results. 100% of us voted that this is congenital syphilis. And of course, you're right. And my point in presenting this differential diagnosis, it's not to confuse you or try to be tricky or anything. It's just to show you that if you weren't thinking about syphilis, the presentation isn't pathognomonic. The baby appears unwell, but it has a lot of different abnormalities, and many of these diagnoses could actually fit that picture as well. So just remember to have congenital syphilis on the differential for babies who have that kind of presentation, even if you don't know about the syphilis history in the birthing parents. So what happens next? The answer is congenital syphilis, of course, as you all got. So syphilis serologies are sent and they're reactive. On the birthing parent, the RPR is now reactive at 1 to 32, and a TPPA is now sent and also reactive. The baby has a reactive RPR at 1 to 16 and a reactive CSF VDRL. So at last, the baby's diagnosis and the mom's are both made correctly. The baby's diagnosed with congenital syphilis, gets started on IV penicillin for a 10-day course, and the mom is diagnosed with early syphilis and receives a one-time dose of bicillin as appropriate. So this story does have a happy ending. Let's talk a little bit more about congenital syphilis and look at some photos. So these are classic physical exam findings for congenital syphilis. But before I even jump into them, I should say this: most infants, in fact, 60 to 90%, are actually asymptomatic, which is why it's really important to send those RPRs and be thinking about testing babies if moms have a history of syphilis in pregnancy or if you don't know mom's syphilis status. But back to babies who are symptomatic. So these are signs and symptoms of congenital syphilis. These are the early manifestations which occur between birth and 8 weeks. These can include things like hepatosplenomegaly, lymphadenopathy. Babies can have a rash. They can have snuffles, which we saw in our case. These are these sort of copious nasal secretions. They're actually sort of pulmonary secretions kind of bubbling up and coming out of the nose, actually. Babies can also have very infectious mucocutaneous lesions. They're called mucus patches like this, or maybe on their genitals. They can have this thing called pneumonia alba, or white pneumonia. This is sort of interesting. This is where there are spirochetes in the pulmonary tissue that cause the lung to become firm and pale with inflammatory cells and fibrosis within the alveolar septa, causing this sort of white pneumonia appearance on path. There can also be bony abnormalities like osteochondritis or pseudoparalysis, which is more of a nerve problem in these babies, and they can have lab abnormalities as well, hemolytic anemia or thrombocytopenia. Again, these are all sort of non-specific findings, however, so just want to put these things on your radar. If you do see babies with constellation or one or more of these symptoms, be thinking about congenital syphilis. These are some photos that were actually shared with me recently by a colleague of babies who were affected by congenital syphilis. What you can see in these photos are some mucocutaneous lesions on the lips and in the oral cavity for this baby. I think there are also some fissures at the corner of their mouth, which can be seen with congenital syphilis. And they also have rashes. So these sort of grayish, scaly lesions on this baby's arm. This was a congenital syphilis rash. Here as well, affecting the palms and soles, this is a pretty dramatic desquamating rash over on the right-hand side of this slide. Perhaps an even more dramatic picture here. This is another baby with early congenital syphilis who has widespread diffuse erythema as well as superficial skin desquamation, again affecting their hands and I imagine also their feet, although not well shown in the photo. But really just want to drive home how dramatic these presentations can be, and again, very sad because this is a preventable disease. So back to our case, just thinking about what factors might have led to the missed syphilis diagnosis in this case. Now, happily, you all were all on top of this and this wasn't confusing for you. But I think for many providers, there can still be a lack of clinical recognition. which is why you should, as I said, treat presumptively. And as you all knew, if you have high suspicion, just go ahead and treat for syphilis, especially late in pregnancy. But the other thing is that there are challenges with syphilis diagnostics. We're going to get into several of them today. But the issue is that the gold standard tests, like a dark field microscopy or a syphilis PCR, they're really not widely available. Most people are not practicing in settings where they have access to those types of tests. So for that reason, syphilis diagnostics relies on these imperfect serologic tests, which have been around for a really, really long time, but don't function perfectly. And the point from this case was that treponemal tests, like the TPPA, FTA antibodies, or treponemal antibodies, EIAs or CIAs, they may turn reactive first before RPRs and VDRLs, but traditional screening algorithms start with non-treponemal tests, usually an RPR. So for that reason, it is possible to miss a very early syphilis diagnosis if you are just sending RPRs. And of course, that's what happened in our case. So I'm going to just look in the Q&A for just a second. I don't see any questions, but feel free to put questions in there if you have them. I'm going to move on to syphilis diagnostics just to show you some more data supporting what we've just discussed with this case. But syphilis diagnostics. So I mentioned the gold standard test being a dark field microscope. Particularly, I think there are only 4 of these on last check in the state of California. There may be less than that now, and I don't know how many, if any, there are in Arizona. But the point is, dark field microscopes are very rare. They're also pretty cool though. So here's a video of what you would see if a person, if we took our case patient and we took a sample of some of that lesion base that we saw in that vulva, and we had a dark field microscope, we put it under there. This is the kind of thing you might see. I'm going to apologize in advance. The music is crazy on this video, but it gives you a sense for what you see under a dark field microscope. It's actually moving spirochetes, which is pretty cool. Hang on. All right, you get the idea. You can see these are these little corkscrew-shaped bacteria, and they wiggle around, they're motile. Pretty cool if you do have a dark field microscope. But again, most people don't have that. We can move on from that. I don't need to make you see it again. So let's talk about serologies, because this is how most of us have to make syphilis diagnostics, is using serologic or blood tests. There are 2 types of serologic tests for syphilis, non-treponemal and treponemal. And you do need both types of tests to make an initial diagnosis of syphilis. So in turn, non-treponemal tests, like we've said, are things like the RPR or the VDRL. And these are quantitative tests, so they allow for assessment of disease burden, treatment adequacy, and reinfection. What I mean by that is they give you a titer, and you all know that. You get a number with RPRs, like it's a 1 to 2, it's a 1 to 32, it's a 1 to 256, something like that. But the thing about RPRs and other non-treponemal tests is that they're non-specific. They're measuring antibodies that are not specific just to treponema pallidum. So they can be positive in patients with other conditions, for example, autoimmune diseases and things like lupus. On the other hand, there are treponemal tests. These are things like the TPPA, the FTA antibodies, the EIAs, and the CIAs. These tests, the treponemal ones, they do detect antibodies that are specific to T. pallidum. So that's good. You're not going to get false positives in things like lupus or autoimmune diseases. But the thing is, these antibodies usually stay positive for life after an initial infection. So they're not helpful in looking for reinfections, for example. And they're also not quantitative. So again, they can't really be used to assess for reinfection or response to treatment. Once they're there, they're kind of always there. This is the graph that kind of points out the main point I was trying to make with the first case. But here you can see a graph showing This is a publication that shows on the y-axis the percent of patients who are testing positive for different types of syphilitic serologic tests. And on the x-axis, you'll see time since infection or exposure. The orange line represents treponemal antibodies, like a TPPA, whereas the green line represents non-treponemal antibodies, like an RPR. And the main point I want to make is just, as we've already discussed, the TPPA in some folks will turn positive first. So what would happen in the very, very early stages, if you had that ulcer, if you got the dark field microscope, if you had that crazy video, you would be able to see the little spirochetes. Shortly thereafter, the person would develop positive treponemal antibodies like TPPAs. And then it could still be another week or so before you start to see the RPR turn reactive. All right, so this is the management issue with primary syphilis. The RPR may be non-reactive in around 25% of primary syphilis cases like ours, especially early on. The RPR and the VDRL may have slightly lower sensitivity than the TPPA for that reason in early primary syphilis. So that means patients may have a non-reactive RPR, but their TPPA could be reactive, and this could be syphilis in the right clinical context. So what do you do? If the RPR in your patient is non-reactive and you really don't suspect syphilis and you think they're going to follow up, then you can likely just repeat in 2 to 4 weeks after the onset of a lesion. So let's say your patient says, I haven't had sex in the last 6 months, I cut myself shaving, I have an ingrown hair. If you really think they haven't had sex, that really looks like a folliculitis or something like that, it is okay to not go ahead and treat them, but if you don't treat them, I would suggest repeating in 2 to 4 weeks after the lesion onset, just to make sure the RPR is not going to turn reactive in the future. On the other hand, as was the case in our patient, if the RPR is non-reactive, but your suspicion is high, do empirically treat and do repeat serology in a week or so. There is really a low threshold to do this in pregnancy. The risks of not treating far outweigh any risks associated with giving Bicillin. All right, let's move on. Now you have the patient's male partner. So the male partner presents with a diffuse rash. This male partner has HIV. Now, happily, they are on antiretroviral therapy and their viral load is undetectable. So because of U equals U, undetectable equals untransmissible, you're not really worried about sexual transmission of HIV in this relationship. The rash looks like this. And the provider does, you do check an RPR and it's non-reactive. What do you think is the most likely diagnosis? You can go ahead and launch the next poll, please. Thanks. Is this secondary syphilis? Is it tinea versicolor? Is it hand, foot, and mouth disease, which is caused by the Coxsackie virus? Is it atopic dermatitis, or is it contact dermatitis? Okay, let's see the answers. Okay, we do have a mix here. 80% or so favoring secondary syphilis, but 20% thinking tinea versicolor. And I think that is the point. So the answer is secondary syphilis, and I'll show you why in a minute. But I also just wanted to take this opportunity to point out the fact that if you didn't have this history, this patient's been exposed to syphilis, they probably also have syphilis. If you didn't have that history and you're just seeing a patient in clinic with a pretty non-specific maculopapular rash, it would be really easy to be thinking of any of these diagnoses, and in fact, perfectly reasonable to be thinking of any of these diagnoses. But that's one reason why keeping syphilis on your differential for diffuse rashes is really important, so that you don't miss it, because it can be subtle, it can look like a lot of other things. So let's talk for a minute about secondary syphilis. This may also be review for some of you, but I do want to just show some of those pictures to point out the variety of manifestations that can happen with secondary syphilis, as well as kind of how subtle and or atypical those presentations may be. Going back to our natural history slide, again, we had our exposure, we talked about primary syphilis. I want to point out again that that chancre of primary syphilis does go away on its own, even in folks who never get treated. And then about 2 to 6 weeks later, the patient will enter the phase known as secondary syphilis. Secondary syphilis is characterized by the things you see on this slide. So rash is the most common in secondary syphilis. It often involves the palms and the soles. Can also present with generalized lymphadenopathy, constitutional symptoms, kind of like a flu-like illness. So patients might have low-grade fever or malaise or sore throat or headache, those sorts of things. Secondary syphilis can also present with oral lesions called mucus patches or condyloma lata, which can look a bit like anogenital warts, and which we'll talk about in a moment. Folks with secondary syphilis can also have patchy alopecia, or it's not shown in this slide, but they can get a subclinical hepatitis, which for whatever reason actually tends to have an alk phos elevation that's a bit out of proportion to the other LFTs. These symptoms of secondary syphilis also typically resolve on their own, even if the patients do not get treated. So here are some pictures. This is sort of the classic diffuse maculopapular rash. Here on the right, you can see this rash does involve the palms and the soles. It can also look sort of atypical. So this rash in the middle here, this does involve the palms and soles, but it looks sort of old, kind of scarred down. I could see folks thinking like, oh, this just looks like an old scar if you didn't remember to think about secondary syphilis. So any lesions on the palms and the soles, be thinking about secondary syphilis. But even if you see a rash like this that doesn't involve the palms and soles, don't forget about syphilis. Here is the differential diagnosis, and this is not an exhaustive list, but just some other rashes that can look a lot like secondary syphilis, and that does include tinea versicolor, so reasonable to think about that. Does include pityriasis rosea, does include erythema multiforme. In addition, this is a patient I saw in the inpatient infectious diseases service. He did not have syphilis, he was just allergic to vancomycin, but you can see the rash is pretty similar. This wasn't itchy for him. Kind of looked like secondary syphilis, which is why I took this picture to show you all. And my point in doing this is just, again, this rash can be pretty nonspecific, it can be pretty subtle. Keep syphilis in mind. These images show examples of mucus patches, which we talked about. There are these lesions in the mouth. They are very infectious. There's sort of whitish gray plaques can appear anywhere in the oral mucosa. And they can easily be confused with other diagnoses that cause white plaques in the mouth, such as thrush or oral hairy leukoplakia. So let's look at those. The purpose of this slide is just to kind of compare and contrast the mucus patches of syphilis with some of the alternative diagnoses that can also cause white plaques in the mouth, like we talked about. So on the left, you see this is oropharyngeal candidiasis, or thrush. This is a diffuse whitish yellow lesion caused by candida. I think the distinguishing feature would be classically if you were to open this patient's mouth, have them open their mouth, put a tongue depressor in, and then try to scrape off some of this whitish material. If it's thrush, it should be able to be scraped off, whereas if it's a mucus patch, that should not be the case. On the right-hand side of this slide, you see oral hairy leukoplakia. This is a disease of the oral mucosa. It's caused by the Epstein-Barr virus, typically seen in folks with HIV. I think what you see well on this slide is that patients with oral hairy leukoplakia tend to have to stick out their tongue and direct it over to the side because this lesion tends to appear on the lateral tongue. What you don't see too well, but what is sort of classic, as I understand it, for oral hairy leukoplakia is these sort of vertical lines that traverse through it. Anyways, if you see any white plaques in the mouth, just remember that syphilis can do this, these mucus patches, and keep that in your differential diagnosis. Here on this slide, you see the patchy alopecia of secondary syphilis. And I just want to point out that this could be very easily confused with something like alopecia areata, which is just regular hair loss, and this is another place where a syphilis diagnosis could be easily missed. Here you see condyloma lata. This is a term for these large, raised, whitish or gray lesions that are found typically in warm, moist areas like the perivulvar area, the perineum, or around the anus. Like mucus patches, these lesions are highly infectious. And in terms of differential diagnosis, this can be really easily confused with anogenital warts. So basically, if you see what you think is a condyloma acuminata or a wart, also be thinking about condyloma lata and secondary syphilis. I didn't put an audience response question on this slide, but just be asking yourself, like, do you think this is condyloma lata, or do you think these are anogenital warts? In this case, this was a condyloma lata, but I think if you were seeing this patient, it could be hard to tell. Just for the sake of comparing and contrasting, I did put a picture in here of a pretty significant condyloma acuminata, so an anogenital wart caused by HPV. This is a really dramatic version of this. I don't think every wart looks this significant. But the point is that where the condyloma lata that we've seen before are sort of flat on top, the condyloma acuminata, or the warts, tend to have like a more irregular or cauliflower-like appearance, as you can tell. So going back to serologies, remember that I said it takes 2 types of serologic tests to make a new diagnosis of syphilis. Here you can see the typical patterns of serologic results that you are most likely to see in secondary syphilis. Depending on which algorithm you're using for your syphilis testing, you're probably either going to see a reactive RPR with a high titer plus a reactive TPPA, or you're going to see a reactive EIA and a reactive RPR. Again, titers tend to be relatively on the high side in secondary syphilis. Not a hard and fast rule, but it does tend to be the case. So back to our case, remember this was a male patient, he has well-controlled HIV. We know he was exposed to syphilis. He has a diffuse rash. We know it in the end, it is secondary syphilis, but why do you think that RPR was non-reactive? And thank you for launching the poll. So I gave you 3 choices here. Do you think the lab just got confused and they just mixed up our patient's serum with the serum of another patient? It does happen from time to time, could be that. Or do you think there was just such a high concentration of antibodies in the initial patient blood sample that the RPR was falsely negative? Or do we not know? Which is totally fine, by the way. The point of these questions is definitely not to be right or be wrong. It's more to test yourself and then hopefully to learn something new. Okay, you can go ahead and show the results. Wonderful. Okay, so 20% of us have no idea, which is totally fair. And then 80% think it's about the concentration of antibodies just being so high that the test didn't work. Thank you all for the votes. So that is the correct answer, actually. It's B. This has to do with the concentration of antibodies in the initial patient sample. But let's talk about that a little bit more. To understand that in more detail, we have to talk about RPRs and we have to talk about the prozone effect. First, I'm just going to talk about the RPR test. How do you perform an RPR test? This is how it works. So you first take a sample of patient serum, you use a little pipette, and you put that sample on circles on a little plastic card like this. Once your sample's on the circles, you take a pre-mixed solution. This is called an RPR antigen or an RPR charcoal antigen sometimes. And this mixture, this antigen mixture, it's pre-prepared and it contains a series of compounds including cholesterol, nonspecific cardiolipin, and something called lecithin, along with that charcoal that I mentioned. It's not super important that you remember those substances, but essentially these are antigens, or basically things that are going to react with certain types of antibodies that a person forms if they're infected with syphilis. We talked about this before, but the type of antibodies that are measured by this test in a patient's blood sample, these are the non-treponemal antibodies. So just other types of antibodies that are typically released when a person is infected with syphilis. Okay, so let's review. You have your serum, it's on these little circles on this card, and then you add this antigen, this pre-prepared antigen. What happens next is that if certain types of non-treponemal antibodies are present in the patient's serum, they will form a complex, an antigen-antibody complex, that will then precipitate out as these visible collections. Because there's charcoal included in this antigen mixture, which is like a black color, the complexes, the antibody-antigen complexes, they show up as agglutinated particles with a dark color on these cards. And I'll show you that on the next slide. This is a really old looking card, and I picked it just to sort of drive home the point that this is an old test. And this is just an example of what the tests look like when it's reactive and when it's not reactive. So if the antigen-antibody complex forms and precipitates out, you'll get a reactive result, which means on the circle, you'll see these little particles, which are basically just agglutinated complexes of antibody, antigen, and charcoal. If it's non-reactive, you won't see any of those little dots inside of your circle. And if it's minimally reactive, hard to see in this picture, but you might see a few little dots. You might be asking yourself, so how do you end up with a titer from an RPR? Well, if the agglutination occurs, so if the antigen-antibody reaction occurs and the particles precipitate out together after you mix the serum and the RPR antigen, then you know the titer is at least 1-to-1, which means a reaction is happening. You could think about it like 1 drop of serum to 1 drop of antigen. What happens next is that the lab can perform serial dilutions of the patient's serum sample on the subsequent circles on this card. Essentially, they're just using like a more and more dilute patient sample mixed with the same antigen mixture. The titer number is represented by the most dilute sample in which agglutination still occurs. Basically, that means the titer number, again, is determined by these progressive dilutions, non-reactive. In this case, you still see, if you look closely, some little dots here representing the particle agglutination that happened, the antigen-antibody complex agglutination that happened. And when you get to a dilution of 1-to-128, you really don't see those little black dots anymore. So this patient would be read as having an RPR titer of 1-to-64. Okay, so what is the prozone effect? The prozone effect is what happened in our patient. This is essentially one of the reasons that you can get a false negative RPR. I think the image I've included here shows the basic concept. On the right, you can see a more optimal ratio of antibodies to antigen. This will result in visible agglutination of the complexes on the RPR card, just like we saw before. However, in some cases, if a patient has a super high concentration of these non-treponemal antibodies, which are represented by these little Ys here, if there's just so many antibodies floating around, there may not be enough antigen in the prepared antigen mixture for the antigen-antibody complexes to ever form. And this is what we're looking at on the left-hand side here. Because there is this excess of antibodies, there's not enough antigen available to form the complexes, and the agglutination does not happen, resulting in a falsely negative test. This is pretty rare. It occurs in less than 1% of cases, but it might be more common in HIV and in neurosyphilis. What's the solution? You can actually, if you suspect it, ask the lab to dilute that initial patient serum sample even more, and then run the whole test again. I'm definitely not suggesting you need to do this in every case because, again, it's rare. But I think in a situation like this, where you really think this patient has been exposed to syphilis, they have symptoms of syphilis, if you're not just going to treat them empirically and you really want to know the RPR number, which is helpful, this is the solution. Think about prozone effect. Ask the lab to dilute that initial sample. That is a tricky topic, so I'm going to stop for just a second and see if anybody has any questions they want to bring up here. It can be about the prozone effect, it can be about antigen antibody, or it can be about anything we've covered up to this point. Nope. Okay, I'll move on to our third case. Our third case is, this is a real patient of mine seen in HIV primary care. This is a cisgender female who has HIV, obviously. And this is her story. This is a 53-year-old cis woman who has sex with men. She does have HIV. Oh, Q&A. I see. So somebody did ask a question, which is a good one in the Q&A, and I think I'm going to answer that now. I'm just going to go back to when we're talking about titers, which is basically here. The question is the condition improving as the titer decreases from 1 to 64 to 1 to 32? It's a really good question. And I would actually say that 1 to 32 and 1 to 64, they're a twofold difference, meaning 32 times 2 is 64. A twofold difference is totally within the margin of error of the test. I will talk about this more in a minute. So I wouldn't interpret a change from 1 to 32 to 1 to 64 as being really clinically significant. But in general, after you treat a patient for secondary syphilis, you do want to see those titers come down by 4-fold or more to indicate that you have successfully achieved treatment. That's not going to happen right away. For early syphilis, it can take a year for the titers to achieve that 4-fold decline, but it should happen if the patient has been successfully treated and not re-exposed. Really good question. And again, syphilis titers, really, really confusing. We'll talk a bit more actually with the upcoming case around how you think about titer interpretation. Great. All right. Just want to make sure I'm not missing anything. Looks like we answered those questions. Wonderful. Okay. So back to this patient who is my primary care patient. Again, she's 53, she has sex with men, she has HIV, it is very well controlled. So her CD4 count's now in the 800s. She's had an undetectable viral load for quite some time, and she is taking her antiretroviral therapy for her HIV. She established care with me as her new PCP in December of 2020. Just to tell you a little bit more about her, this is her HIV history. She was diagnosed in 2017. She acquired her HIV through sexual transmission with her male partner at the time. She's never had an opportunistic infection. Her CD4 nadir was around, meaning her lowest CD4 ever was around 300. And she does take, as I said, her HIV medications. She's on one called dolutegravir and one called Descovy, and she has achieved viral suppression. Just a little bit more about her social history. And the reason I'm mentioning this is because I think some of these social determinants of health or certain behavioral activities do tend to show up in folks who end up having syphilis. So she has substance use disorder. She uses alcohol and she uses methamphetamine, including via injection use. She has a history of unstable housing and has experienced homelessness in the past. When I met her, she was housed and she was living in an SRO, which is a single room occupancy. So I'm going to tell you about her syphilis results. Again, I met her here in December of 2020. I looked back at her syphilis results and I saw that happily she had been screened for syphilis in 2019 and again in 2020, and she had non-reactive RPRs. I asked her about her sexual history and I found out that she was still sexually active with male partners. I knew she was still using methamphetamine, so I decided I should screen her for syphilis again. And here's the results that I got. When she came back to have her tests done in January of 2021, so this was about a month after I met her, she had a T pallidum antibody that resulted as inconclusive, an RPR that was still non-reactive, just like it had been, and a TPPA that was reactive. So I thought, I don't know what to make of that inconclusive result. I'm going to repeat it. So I brought her back and I repeated the test again. It took a while for her to come back into clinic, but when she came back, this was her results. She had a T pallidum antibody, so like an EIA, that was reactive, an RPR that was non-reactive, and a TPPA that was reactive. So in summary, she now has her same non-reactive RPR, but 2 reactive treponemal tests. I'm now going to ask you a question. How would you interpret her most recent syphilis serologies? Again, that's a non-reactive RPR, 2 reactive different treponemal tests. Would you say she has a new syphilis diagnosis? She has a prior syphilis diagnosis? You have no idea because syphilis is so confusing, or do you need more information? Okay, let's see what the audience thinks. Right, this is great. So we have answers that are sort of mixed. We have about a quarter of folks thinking this is a new syphilis diagnosis, and the majority of folks thinking she has a prior syphilis diagnosis. What I would argue, and again, this is not to be right or wrong, but what I would argue here, just for learning's sake, is that you actually don't know. You need more information to really decide what's going on here. You need to know about any current or recent signs or symptoms, or whether she's been a contact to syphilis. And you do also need to know if she's had syphilis in the past, she's been diagnosed, if she's been treated. And that's the kind of pieces of data that you're going to use to decide if this is a new infection that you're just finding, or if this is an old treated infection. You really can't tell just based on this combination of serologies. It's also really helpful to know which screening algorithm your lab is using. And this was a learning point for me with this case. So here's the timeline again, and I'll show you what kind of happened. So what happened is before 2019, our hospital had switched to a new electronic medical record. So around that time, it became kind of less easy to access the older history that might have happened to this person before 2019. Then the patient was screened with a traditional screening algorithm in 2019 and 2020. Her RPRs are non-reactive. Our hospital was using a traditional algorithm at that time. But around the time I met this patient, the hospital switched. They switched to the reverse screening algorithm. We'll talk about in a bit, a little bit more about the differences between those 2 algorithms. But it was after that change that my patient's syphilis tests were suddenly reactive. And to understand why this happened and what happened to the patient, we really do need to understand how the different syphilis screening algorithms are performed and how you interpret them. I think this is one of the most tricky things about syphilis. I'm going to try to make it as understandable as I can. But again, please feel free to stop me and ask questions if any of this becomes unclear. So let's review. We went over this before, but just to make sure we hit this point again, these are the serologic tests for syphilis. And again, for an initial syphilis diagnosis, you do need both types of tests. The non-treponemal tests are that RPR with the antigen-antibody complexes, that card that we looked at. That's a non-treponemal test, and they're quantitative. You dilute the serum out, and it gives you a titer, and they're non-specific. They can have issues with false positives in folks who have other conditions like lupus or other autoimmune diseases. Then again, we have our treponemal tests, our TPPA, our EIA, our CIA, specific to syphilis, so that's good, but positive for life in most patients, and not quantitative, no titer. So there's 2 ways you can screen for syphilis. Each way involves both types of tests. We've got the traditional screening algorithm, and we've got the reverse screening algorithm. The reverse screening algorithm is actually being used more frequently in many settings, and this is what my hospital has recently started using. And this was around the time when I met that patient, as I mentioned. So let's kind of go through each of these screening algorithms and try to understand what might have happened in our case. So here we have the traditional screening algorithm. And again, this was what was being used on my patient before I met her. In a traditional screening algorithm, and I'll back up and say I'm going to try to go kind of slow here because, I think this is one of the most tricky topics that we have to deal with in syphilis, and I want to make it as understandable as I possibly can. So in the traditional screening algorithm, you start with an RPR. In this algorithm, if the RPR is negative, you're done. Testing stops. This is what happened with my patient. The patient is not diagnosed with syphilis by this algorithm. So my patient was just being screened this way prior to 2021. Her RPRs kept coming back non-reactive. Great, she doesn't have syphilis. Just to kind of talk more about the algorithm though, let's say the RPR came back and it was reactive or positive. If the RPR is positive, then the test should reflex to a treponemal test, usually the TPPA. Now, if the TPPA is negative, syphilis is unlikely, and that positive RPR is generally considered a false positive. However, with the traditional screening algorithm, if the RPR is positive and you have a TPPA that's positive in that context, this does indicate that the patient has either past or present syphilis. The patient's sort of clinical and testing history can then be used to explore these possibilities. So this can either be an old treated infection where the RPR is still just coming down, but you don't need to treat it again. This could be a prior infection that you never knew about that does need to be treated, or this could be a brand new infection that just happened. The information that you kind of need to make those determinations includes the things you see on this slide. So like any signs or symptoms of primary or secondary syphilis, any prior syphilis diagnosis and treatment history, and any prior RPR titers, with a fourfold change from prior being considered clinically significant. So that's the traditional algorithm. To make it even more complicated, I do want to add in a few caveats. So back here up at the top, remember that even if the RPR is non-reactive, you should treat presumptively and check a TPPA if you have really high clinical suspicion. That gets back to that first case where we had our pregnant person with the vulvar lesion. Another caveat to think about is in these cases where you have discordant results, like let's say the RPR was reactive, but a TPPA was non-reactive. If this is a scenario where you think it's pretty likely that the patient could have been exposed, or if they're pregnant, if you're not going to treat them right away, which you probably wouldn't, I would rescreen them in 2 to 4 weeks, particularly if it's a pregnant person. If I had a reactive RPR and a TPPA that was non-reactive, the person is pregnant, the person is sexually active, I would just rescreen in 2 to 4 weeks as a precaution. If things stay the same and you keep these discordant results, then it's fine. The RPR is a false positive. There's nothing you need to do. The rescreen, again, is just a precaution. So that's the traditional algorithm. I'm going to check the Q&A really quickly and make sure there's no questions on that. Oh, okay. I do see some questions in the chat. Thank you. I see one that says, why does a test result to a false positive? Why do false positives happen with RPRs? The reason is because the antibodies that the RPR test is looking for are these non-specific antibodies. They're antibodies that are released kind of in response to inflammation. And that does happen with syphilis, but it also happens with other conditions. So the classic examples are like lupus and rheumatoid arthritis, kind of autoimmune type diseases where there is inflammation, kind of non-specific inflammation. And that can cause this test to be falsely positive. Thanks for the question. All right, so that's the traditional algorithm. And we went through all the different scenarios that can happen with that. Next, We're going to look at the reverse screening algorithm. This is, as I mentioned, being used a bit more frequently in some settings. And the reason is actually because the RPR is such a manual test. The reverse screening algorithm is oftentimes more simple and easier for labs to perform. So we are seeing this more and more often. Okay. With the reverse screening algorithm, sorry, I'm actually going to pause for just 1 second. My battery is dying. Hang on. Okay, I apologize for that. Can you all still hear me okay? Dr. Adler, do you hear me okay?
Yes, we can hear you.
Okay, wonderful. Thank you. I didn't want to jump into the reverse screening algorithm with my computer not plugged in. Just could have been really bad. Okay, so with the reverse screening algorithm, you start with a treponemal test. It's usually an EIA or a CIA, like an enzyme immunoassay or a chemiluminescent immunoassay. If the EIA or CIA is non-reactive, then that's it. Again, testing stops, the algorithm is done, the patient is not diagnosed with syphilis. But if the EIA or CIA is positive or reactive, as was the case with my patient when we switched to using this algorithm, then a standard RPR is performed next. If the RPR is reactive, just like with the traditional screening algorithm, you have diagnosed either past or present syphilis, because at that point you have a reactive treponemal test and you have a reactive RPR. So then, just like before, you use the clinical history and any prior RPR titers and any prior syphilis diagnosis and treatment history to figure out if you think this is an old or new infection. In our case, though, the RPR was non-reactive or negative. In this situation, in the reverse screening algorithm, the test should reflex to a second treponemal test and a third overall test. It's usually a TPPA. And this is done, you can think of it kind of like a tiebreaker, basically. If you have a reactive EIA, you have a non-reactive RPR, and then you get a TPPA, and it's negative, that usually means that syphilis is actually unlikely. By contrast, if the TPPA is reactive, you now have two treponemal tests that are different, that are both reactive, and you have diagnosed either past or present syphilis. Management at that point really depends on the clinical scenario. I'm going to spend some time on that with the next slide. So here is a slide showing possible interpretations of our patient's combination of serologies. So she had EIA reactive, RPR non-reactive, TPPA reactive. In this situation, remember that treponemal antibodies, EIA and TPPA, they do stay positive for life. So this can be latent or prior syphilis, and it may have been treated or it may have been untreated. We don't know. All we could know at this point is like this patient has or had syphilis. This was not my patient's case, so I'll just give you that off the bat, but this combination of serologies could technically also be early syphilis, and you're just catching it prior to the RPR having seroconverted. So let's talk about recommended actions. Basically, you actually don't need to do anything if your patient, if you know, okay, my patient had syphilis in the past, they were treated appropriately, they were not re-exposed, they don't have any new symptoms, and their exam is totally normal, you could just consider this a prior infection. If you know, again, the patient they've had syphilis, they've been properly treated, they weren't re-exposed, they don't have any symptoms, you don't have to do anything. On the other hand, if they don't have any symptoms, but you also don't know if they've ever had treatment for syphilis, then what you should do is treat them. You should treat presumptively for late latent or unknown duration syphilis, because in this case, you really don't know when this infection might have occurred. And the treatment, of course, is bicillin given weekly, intramuscularly for 3 weeks. And then the final scenario is if you really suspect early syphilis, either because the patient has convincing symptoms or they had a known exposure, you should go ahead and treat. get an RPR on the day that you treat, and then even if that RPR is non-reactive on the day of treatment, still consider repeating in a few weeks to assess for seroconversion. I left these two in bold because I really want you to focus your attention here for this combination of syphilis serologies. Basically, we need to decide if our patient has syphilis that's already been treated in the past and there's nothing new to do, or we need to treat her for late latent or unknown duration syphilis. Before I jump into what happened in the case, I just want to show you a resource. This is actually one of the main and perhaps my most important learning objective for this whole talk. I just want you to know that the California Prevention Training Center does have this resource. We can send it out with the materials from this course. This is a PDF that shows the 2 different algorithms for syphilis screening, and it provides a series of possible interpretations as well as recommended actions depending on what combination of serologic results you're looking at. I find this to be a really, really helpful resource. I think it's even more helpful than knowing in your head all of this information, because I think it can still be really easy to get confused with syphilis, and I love having this all written down on paper in just one place. So hopefully a solid plug for that resource and something that you might consider using in your practice. All right, what happened to my patient? So I did do a physical exam and I asked her a lot of questions about signs and symptoms. Have you noticed any sores? Have you noticed any rashes? Have you noticed any hair loss? Do you have any sores in your mouth? I did a neuro exam. No neurologic deficits, no trouble with vision, no trouble with hearing. She also said, yeah, she'd been sexually active, but it was with the same partner she'd had for a long time. She was not aware of any new syphilis exposures. Then what I did next is I contacted our San Francisco Department of Public Health for prior records. And it turned out that this patient had been adequately treated for syphilis in the remote past. Given that, as well as her lack of treatment and the fact that she actually hadn't really had any new partners, we decided that it was not necessary to repeat this treatment for the patient. She's one of those people that probably just has the reactive treponemal tests for life. So her EIA and her TPPA, the treponemal tests, they're always going to be reactive. And in fact, they're probably not that helpful to send on her in the future. What should happen for her is that she should be monitored with RPRs only moving forward. Remember, as we've said, again, that the EIA, TPPA, all those treponemal tests, they do often stay positive for life after prior infection, which means they're really not helpful. And what should have happened in this case is that she should have just kept on being screened with RPRs. In a person with a history of syphilis, RPRs do become, by themselves, the appropriate screening test for your patients. So that's the end of the case. I want to talk more about titers. I know we've already had some questions come up about this in the chat. So the question is, what about patients with a history of syphilis? How do you interpret those non-treponemal titers? Well, it's true that higher numbers correspond to higher levels of antibodies in the patient's serum. But this is a manual test, the RPR, like we talked about before. Basically, to get that agglutination to happen on those cards, somebody in the lab or else a machine, they're sort of like rotating around this card to cause this mixing reaction to happen, to cause these particles to form. And then they're looking at it visually and saying, do I see dots there? Do I not see dots there? So it is a manual test. And for that reason, a twofold change is generally considered within the margin of error for this imperfect test. Question that we get from time to time is like, what do you mean by a twofold change? What do you mean by a fourfold change? I agree, that terminology is kind of confusing, but the concept is pretty simple. A twofold change is basically like this: a 1 to 16 or a 1 to 1 to 32. You basically multiply one thing by 2 to get the other. So a twofold change from 1 to 16 would be 1 to 32. Why? Because 16 times 2 is 32. On the other hand, a fourfold change is, especially if sustained for at least 2 weeks, that is what is considered to be clinically significant. A fourfold change, for example, from 1 to 2, would be going all the way up to 1 to 8. Why? Because 2 times 4 is 8. It's important to recognize, as I put on the slide here, that you really, whenever possible, do want to compare titers using the same serologic test. For whatever reason, RPRs tend to run a bit higher than VDRLs, so you can't really compare directly an RPR to a VDRL. You really want to compare RPRs to RPRs, and ideally send them to the same lab so that they can be interpreted by the same people or equipment. So my patient, her antibodies, her RPRs were totally non-reactive, so this isn't really relevant to her. But some folks end up with, say they get treated for syphilis, their titers come down after treatment, they achieve a 4-fold decline. So if let's say they started way up here, their initial titer was 1 to over 1,000. They might come after treatment all the way down to like 1 to 2. And they may live at 1 to 2. They may never revert all the way to non-reactive. That's okay. They would have achieved their more than 4-fold decline. But if you bring them in to screen them again, and you see that instead of 1 to 2, they're now at 1 to 8, or they're now at 1 to 16, that means that they've probably been reinfected because you're seeing a 4-fold change or more. So that's kind of how to think about RPR and VDRL titers. Again, I know that's a confusing topic. I will pause for just a minute to see if folks have questions about that. Well, there is a question in the chat, and it's a good one. Is the health check point of care test an EIA or a CIA? I actually don't know how they're running their antibody test. It is a treponemal test, the health check, all the point of care tests using like the ChemBio test or the health check, they do use treponemal tests. And I think the point you're getting at, which is an important point, is they're actually not perfect tests for folks who you know have syphilis because they're going to be positive and you won't know if that person's been reinfected or not. So while I think some of those point of care tests, they really do have a role. If you have hard to reach patients, people in correction setting, people who are experiencing homelessness, it's really a good way to get people tested, but you do have to just keep in mind that the test will stay reactive, most likely for life. And so for folks where you were trying to figure out like, okay, I know you have syphilis, have you been reinfected? You would still need an RPR test with a titer to really make that determination. Okie dokie, next topic is syphilis treatment. This is just going to be a really brief review. I'm not going to cover this in detail. But in order to really cover the topic, I do have to go back to the natural history one more time to really dive into latent infections. So you might have heard these terms like early latent or late latent. What do those mean? So we define early latent syphilis as occurring when the only evidence of disease or infection is laboratory evidence and the knowledge that the infection occurred within the past 12 months. So for example, if you know the person had negative syphilis serologies 3 months ago, and now they have reactive syphilis serologies, then you know, okay, that infection occurred within the last 12 months. Or if the person has never had sex before, and then they have sex like last month, and now they have reactive syphilis serologies, well, then you know for sure this is an early infection. Even though they're asymptomatic, you're within the first 12 months. If you can prove that by serologies or by the history, then you've diagnosed early latent syphilis. If you get beyond that, beyond the 12-month mark, we consider this to be syphilis of late latent or unknown duration. Basically, we either have no idea when this infection occurred, or we know it occurred more than 12 months ago. The reason this matters is because the treatment is actually different if you make the call of early latent versus late latent infection. So we'll look at treatment for just a second. I know you all are probably familiar with this, but of course, Bicillin LA is the first-line treatment for all stages of syphilis, but the number of injections that folks need is what is different depending on early versus late. So early syphilis includes primary syphilis, like with that chancre. It includes secondary syphilis with the rash, with the mucosal lesions, etc., as well as early latent syphilis, so asymptomatic syphilis that you know occurred infection-wise within the last year. All of those, primary, secondary, early latent, they're all treated the same. Benzathine penicillin, also known as Bicillin LA, you give 2.4 million units, give it intramuscularly times 1. On the other hand, if a person has syphilis of late latent or unknown duration, that is when you do the 3 weekly injections. So same medication, same dose, but you give injections intramuscularly for 3 weeks. And ideally you want to give them 7 days apart. So that's the treatment. One more time, I have to go back to serologies to talk about the importance of a day of treatment titer. The main point I want to make here is that performing a day of treatment titer is really important to establish a baseline, because that's what you use to compare response after treatment. So let's just say you have a hypothetical case patient and they come into clinic and you test them for syphilis and you diagnose them with syphilis and their RPR is 1 to 256. But they don't want to get treated that day. They want to come back next week. They have something to do right now. So like they have to go to the grocery store, whatever. So they leave clinic. And then they come back next week for their treatment. And at that point, their RPR has actually gone up quite a bit. It's 1 to over 1,000. And they go ahead and get treated. But if you don't check, if you don't know this titer, you'll never know the peak of that RPR. So let's say you never checked, you never had this really high number. And then 6 months later, the patient comes back and you screen them again. If you saw that RPR at 1 to 256, it's really hard to know. You might be thinking like, oh no, this treatment didn't work. This patient's titer didn't change at all. They started at 1 to 256 and now they're at 1 to 256. The point is that you missed this one in the middle. If you check on the day of treatment, then you know the peak of the RPR titer and you have something to follow over time. It's much more reassuring to see an RPR of 1 to 256 if you know that on the day of treatment, the RPR was really much higher than that. One more final point about RPR is just to add additional confusion, but I do want to be honest about it, is that RPR titers do tend to come down on their own over time. They may or may not go all the way to non-reactive, even if a person doesn't get treated. So just another tricky thing to keep in mind about RPRs. Okay, I see a comment in the chat, day of treatment RPR, never thought of that. Thank you. Oh, of course, yeah, you're totally welcome. I agree, this is another area where it's really easy to just not even know. I mean, it's like such a nuanced thing, but I think this example highlights it well, why it's so important to get that day of treatment titer. It's mostly to save yourself future confusion. All right, and I was going to do some rapid fire audience response questions. We have 1 more minute. Dr. Adler, what do you think? Should we open it up for Q&A or just do some images?
I think you could do some images. I just want to let folks know we know we're running a teeny bit late. So if you have any questions, put them into the Q&A.
I'm just about done. These are really the last things. I won't even do the polls here. I'm just going to ask you all to think for yourselves each image that I'm going to show. What is this? All right, this image. Several pustular vesicular lesions here, some eroded skin here. What do you think this is? Syphilis? Herpes? Mpox? Oh, we launched the poll. Okay, all right. What do you all think? Okay, you can go ahead and show the results. Okay, we're split, primary syphilis or herpes. Good. I'm not going to tell you the answer right now. What's the next one? You can launch the next poll. We'll do them really quickly. Okay, 4 seconds. 4, 3, 2, 1. All right, let's show the poll. Totally mixed here. Primary syphilis, herpes, or Mpox, all in the votes. Okay, I won't show you the answer. I'm going to do 2 more images. What's this one? Okay, you can show the results. This is a mix, primary syphilis or Mpox is what we're thinking. Okay, and the last one. What is this one? Okay, get to the results. Also a mix here. Great, and I think that's the whole point I'm trying to make. So these were the correct answers. The first one was herpes, the middle 2 were both syphilis, but really atypical presentations, and then the final one was a really atypical presentation of Mpox. The point is, you should be thinking about all of these things, and if you see a lesion about this, I would test for herpes, I would test for syphilis. If you have the ability at your setting, I would consider Mpox if you see something along these lines. So I know we're at time. I am not going to go over all the take-home points. The main one I want you to remember is that we do have a resource for helping to interpret syphilis serologies, and we'll send that out with the materials from this webinar. I want to thank all these people who are wonderful for contributing slides or thoughts to this talk. And I think we've been answering questions all along. So I'll turn it over to you, Dr. Adler. We can probably just finish up because I know we're at time.
Thank you so much, Dr. Johnson, for that fabulous presentation. You're already in the Q&A because we don't have an open chat. You've got to thank you for that great presentation. So that was one of your questions. You're getting a bunch of other thank you, very helpful. So that was a really wonderful presentation.